Good health throughout the life cycle begins with the individual. Women today can expect to live well into their 80s and need to be proactive in maintaining their own quality of life. Women need to take steps to reduce their risk of disease and need to become active partners with their healthcare professionals to identify problems early when treatment may be the most successful. Nurses can assist women in maintaining their quality of life by helping them to become more attuned to their body and its clues, and can use the assessment period as an opportunity for both teaching and counseling. Common reproductive issues that will be addressed in this video include menstrual disorders, infertility, contraception, and the menopausal transition. Menstrual disorders. Many women sail through their monthly cycles with little or no concern. With few symptoms to worry about, their menses are like clockwork, starting and stopping at nearly the same time every month. For others, the menstrual cycle causes physical and emotional symptoms that initiate visits to their healthcare providers for consultation. The following menstrual-related conditions will be discussed in this video: amenorrhea, dysmenorrhea, dysfunctional uterine bleeding or DUB, premenstrual syndrome or PMS, premenstrual dysmorphic disorder or PMDD, and endometriosis. Amenorrhea is the absence of menses during the reproductive years. Amenorrhea is normal in prepubertal, pregnant, postpartum, and postmenopausal females. The uterus, the endometrial lining, the ovaries, the pituitary, and the hypothalamus must all function properly and in harmony with one another for a menstrual cycle to occur. The two categories of amenorrhea are primary amenorrhea and secondary amenorrhea. Primary amenorrhea is defined as one of the following: either the absence of menses by age 14 with the absence of growth and development of secondary sexual characteristics, or the absence of menses by the age of 16 with the normal development of secondary sexual characteristics. 98% of American girls begin menstruation by the age of 16. Secondary amenorrhea is the absence of menses for 3 cycles or 6 months in women who have previously menstruated regularly. Primary amenorrhea has multiple causes, including extreme weight loss or weight gain, congenital abnormalities of the reproductive system, stress from major life events, excessive exercise, eating disorders such as anorexia nervosa or bulimia, Cushing's disease, polycystic ovary syndrome, hypothyroidism, Turner syndrome, imporfirate hymen, chronic illnesses including diabetes, thyroid disease, or depression, pregnancy, cystic fibrosis, congenital heart disease, or tumors of the ovaries or adrenal glands. Causes of secondary amenorrhea include pregnancy, breastfeeding, emotional stress, pituitary, ovarian, or adrenal tumors, depression, hyperthyroidism or hypothyroidism, malnutrition, hyperprolactinemia, rapid weight loss or weight gain, chemotherapy or radiation therapy to the pelvic area, vigorous exercise such as long-distance running, colitis, kidney failure, use of certain tranquilizers or antidepressants, postpartum pituitary necrosis, or early menopause. Therapeutic intervention depends on the cause of the amenorrhea. The treatment of primary amenorrhea involves the correction of the underlying disorder and estrogen replacement therapy to stimulate the development of secondary sexual characteristics. If a pituitary tumor is the cause, it may be treated with drug therapy, surgical resection, or radiation therapy. Surgery may also be needed to correct any structural abnormalities of the genital tract. Dopamine agonists are effective in treating hyperprolactinemia. In most cases, the treatment restores normal ovarian endocrine function and ovulation. Therapeutic interventions for secondary amenorrhea include cyclic progesterone when the cause is anovulation or oral contraceptives, bromocriptine to treat hyperprolactinemia, nutritional counseling to address anorexia, bulimia, or obesity, gonadotropin-releasing hormone or GnRH when the cause is a hypothalamic failure. or thyroid hormone replacement therapy when the cause is hypothyroidism. Some tips for maintaining a healthy lifestyle for women wanting to stay reproductively healthy or women experiencing reproductive issues are the following. Balance energy expenditure with energy intake. Modify the diet to maintain an ideal weight. Avoid excessive use of alcohol or mood-altering or sedative drugs. Avoid cigarette smoke. Identify areas of emotional stress and seek assistance to resolve them. Balance work, recreation, and rest. Maintain a positive outlook regarding the diagnosis and prognosis. Participate in ongoing care to monitor any medical conditions. And maintaining bone density. Maintaining bone density can involve one or more of the following. A calcium intake of between 1,200 to 1,500 milligrams daily, vitamin D intake of 1,000 IUs daily, weight-bearing exercise for 30 minutes or more daily, and hormone therapy. Dysmenorrhea refers to painful menstruation. This condition has also been termed cyclic perimenstrual pain. The term dysmenorrheal is derived from the Greek word dys, meaning difficult, painful, or abnormal, and rhea, meaning flow. Dysmenorrhea may affect more than half of menstruating women. Uterine contractions occur during all periods, but in some women, these cramps can be frequent and very intense. Dysmenorrhea is classified as primary when they are spasmodic or secondary when it is more congestive. Primary dysmenorrhea is caused by an increase in prostaglandin production by the endometrium during the ovulatory cycle. This hormone causes the contraction of the uterus, and levels tend to be higher in women with severe menstrual pain than in women who experience mild or no menstrual pain. Prostaglandin levels are the highest during the first 2 days of menses when symptoms usually peak. This results in an increase in rhythmic uterine contractions caused by vasoconstriction of the small blood vessels of the uterine wall. This condition usually begins within a few years of the onset of the ovulation cycles at menarche. Secondary dysmenorrhea is painful menstruation due to pelvic or uterine pathology. It may be caused by endometriosis, adenomyosis, pelvic inflammation, fibroids, an intrauterine device, cervical stenosis, or congenital uterine or vaginal abnormalities. Adenomyosis involves the ingrowth of the endometrium into the uterine musculature. Endometriosis involves the ectopic implantation of endometrial tissue in other parts of the pelvis. This condition occurs most commonly in the 3rd or 4th decades of life and affects 10% of women of reproductive age. Endometriosis is the most common cause of secondary dysmenorrhea and is associated with pain beyond menstruation, dyspareunia, low back pain, and infertility. Treatment is directed toward removing the underlying pathology. Severe dysmenorrhea can be distressing, adversely affecting social and occupational activities. Treatments vary from over-the-counter remedies to hormonal controls. However, for some women, satisfactory pain relief is difficult to achieve, and alternative options are increasingly being sought. Complementary therapies such as acupuncture are gaining popularity, and the evidence base for their use is growing. Therapeutic intervention is directed toward pain relief and building coping strategies that will promote a productive lifestyle. Treatment measures usually include treating infections if present, suppressing the endometrium if endometriosis is suspected by administering low-dose oral contraceptives, administering prostaglandin inhibitors to reduce pain, administering Depo-Provera to suppress ovulation, which thins the endometrial lining of the uterus with subsequent reduction of fluid contents of the uterus during menses, and initiating lifestyle changes. Dysfunctional uterine bleeding. Disturbances of menstrual bleeding manifest in a wide range of presentations. Abnormal uterine bleeding is the umbrella term that is used to describe any deviation from normal menstruation or from a normal menstrual cycle pattern. The key characteristics are regularity, frequency, heaviness of flow, and duration of flow. However, each of these may exhibit considerable variability. More descriptive terminology is currently being deliberated internationally. Dysfunctional uterine bleeding, otherwise known as DUB, is a disorder that occurs most frequently in women at the beginning and end of their reproductive years. Defined as irregular abnormal bleeding that occurs with no identifiable anatomic pathology, it affects up to 50% of women. It is frequently associated with anovulatory cycles, which are common during the first year after menarche and later in life as women approach menopause. The pathophysiology of DUB is related to a hormonal disturbance. With anovulation, estrogen levels rise as usual in the early phase of the menstrual cycle. In the absence of the ovulation, however, a corpus luteum never forms and progesterone is not produced. The endometrium then moves into a hyperproliferative state, ultimately outgrowing its estrogen supply. This leads to irregular sloughing off of the endometrium and excessive bleeding. If the bleeding is heavy enough and frequent enough, anemia can actually result. DUB is similar to several other types of uterine bleeding disorders and sometimes overlaps with these conditions. These may include menorrhagia, which is abnormally long or heavy periods, oligomenorrhea, which is bleeding that occurs at intervals of more than 35 days, menorrhagia, which is bleeding between periods, Menorrhagia, which is bleeding that occurs at irregular intervals with heavy flow lasting more than 7 days, or polymenorrhea, which is periods that occur much more frequently than is usual. Some of the possible causes of DUB may include adenomyosis, pregnancy, hormonal imbalances, fibroid tumors, endometrial polyps or cancer, endometriosis, intrauterine systems, polycystic ovary syndrome, morbid obesity, steroid therapy, hypothyroidism, and blood clotting disorders. The treatment of DUB depends on the cause of bleeding as well as the age of the client. When known, the underlying cause of the disorder is treated. Otherwise, the goal of the treatment is to normalize the bleeding, correct the anemia, prevent or diagnose early cancer, and restore quality of life. Management of DUB might include medical care with pharmacotherapy or insertion of a hormone-secreting intrauterine system. Oral contraceptives are used for cycle regulation as well as contraception. They help to prevent the risks associated with prolonged, unopposed estrogen stimulation of the endometrium. NSAIDs, pain relievers, and Progestin Therapy decrease menstrual blood loss significantly. The drug categories used in the treatment of DOB include estrogens, progestins, oral contraceptives, NSAIDs, progesterone-releasing intrauterine systems, androgens, and iron salts. Estrogens work by causing vasospasms of the uterine arteries to decrease bleeding. Progestins are used to stabilize an estrogen-primed endometrium. Oral contraceptives are used to regulate the menstrual cycle and suppress the endometrium. NSAID pain relievers inhibit the prostaglandins that are secreted in the ovulatory menstrual cycle. Progesterone-releasing intrauterine systems suppress endometrial growth. Androgens create a high androgen, low estrogen environment that inhibits the endometrial growth, and iron salts act to replenish iron stores that may be lost during heavy bleeding. When the client does not respond to medical therapy, surgical intervention might include dilation and curettage, endometrial ablation, or hysterectomy. Endometrial ablation is an alternative to hysterectomy. Techniques used for ablation include laser, electrosurgery excision procedures, freezing, heated fluid infusion, or thermal balloon ablation. Most women will still have regular menstrual flow following endometrial ablation, and up to half will stop having periods. Younger women are less likely than older women to respond to endometrial ablation. Recent scientific evidence supports that up to 1/4 of clients treated with endometrial ablation require repeated ablation procedures or subsequent hysterectomy to stop DUB. Hysterectomy should be considered as a last resort for the treatment of DUB when blood loss impedes health. Premenstrual syndrome. Premenstrual syndrome, or PMS, describes a constellation of recurrent symptoms that occur during the luteal phase or last half of the menstrual cycle and usually resolve with the onset of menstruation. The American College of Obstetrics and Gynecologists defines premenstrual syndrome as the cyclic occurrence of symptoms that are sufficiently severe enough to interfere with some aspect of life and that appear with a consistent and predictable relationship to menses. A woman experiencing PMS may have a wide variety of seemingly unrelated symptoms. For that reason, it is difficult to define and more challenging to diagnose PMS. PMS affects millions of women during their reproductive years. Up to 75% of menstruating women report on having one or more premenstrual symptoms, and up to 10% report disabling, incapacitating symptoms. The exact cause of PMS is not known. It is thought to be related to the interaction between hormonal events and neurotransmitter function, specifically serotonin. Not all women respond to serotonin reuptake inhibitors, or SSRIs, which implies that there may be other mechanisms involved as well. According to the American Psychiatric Association, premenstrual dysmorphic disorder, or PMDD, is a more severe variant of PMS, affecting between 3 and 6% of premenopausal women. Experts compare the difference between PMS and PMDD to the difference between a mild tension headache and a migraine. PMDD markedly interferes with work, school, social activities, and relationships with others. Treatment of PMS is often frustrating for both clients and healthcare providers. Clinical outcomes can be expected to improve as a result of recent consensus on the diagnostic criteria for PMS and PMDD. The management of PMS or PMDD requires a multidimensional approach because these conditions are not likely to have a single cause, and they appear to affect multiple systems within a woman's body. Therefore, they are not likely to be amenable to treatment with a single therapy. To reduce the negative impact of premenstrual disorders on a woman's life, education, along with reassurance and anticipatory guidance, is needed for women to feel that they have some control over this condition. Therapeutic interventions for both PMS and PMDD address the symptoms because the exact cause of the condition is still unknown. Treatments may include vitamin supplements, dietary changes, exercise, lifestyle changes, and medications. The medications used in treating PMDD include antidepressants and anti-anxiety drugs, along with diuretics, anti-inflammatory medications, pain relievers or analgesics, synthetic androgen agents, oral contraceptives, or gonadotropin-releasing hormone agonists. Here are some treatment options for PMS and PMDD. The first category are lifestyle changes. Reduce stress. Exercise 3 to 5 times each week. Eat a balanced diet and increase water intake. Decrease caffeine intake. Stop smoking if you do, and limit the intake of alcohol. And attend PMS or women's support groups. There are also vitamin and mineral supplements which may help, including a daily multivitamin, vitamin E at 400 units daily, calcium at 1200 milligrams daily, and magnesium at a dose of between 200 and 400 milligrams daily. Medications that can be used include NSAIDs or pain relievers that are taken a week prior to menses, a low-dose oral contraceptives, or antidepressants, also known as SSRIs. Anxiolytics, which are taken during the luteal phase of the menstrual cycle, diuretics to remove excess fluid, progestins, gonadotropin-releasing hormone agonists, and danazol, which is an androgen hormone which inhibits estrogen production. No single treatment is universally recognized as effective, and many clients often turn to therapeutic approaches outside of conventional medicine. Many women use dietary supplements or herbal remedies for their menstrual health and treating their bleeding disorders, although there has been little research to demonstrate their efficacy. Alternative therapies include the use of calcium carbonate, magnesium, vitamin B6, evening primrose oil, Vitex agnus cactus, ginkgo biloba, viburnum, dandelion, stinging nettle, chaste tree berry, burdock, raspberry leaf, skullcap, and St. John's wort. Although research has not validated the efficacy of these alternative therapies, it is important for the nurse to be aware of the alternative products that women may choose to use. In PMDD, the main symptoms are mood disorders such as depression, anxiety, tension, and persistent anger or irritability. Physical symptoms such as headache, joint and muscle pain, lack of energy, bloating, and breast tenderness are also present. It is estimated that up to 75% of reproductive age women experience premenstrual symptoms that meet the criteria for PMS, and up to 10% meet the diagnostic criteria for PMDD. According to the American Psychiatric Association, a woman must have at least 5 of the typical symptoms to be diagnosed with PMDD. These must occur during the week before and a few days after the onset of menstruation, and must include 1 or more of the first 4 symptoms, as follows. Affective lability, including sadness, tearfulness, or irritability, anxiety and tension, persistent or marked anger or irritability, depressed mood or feelings of hopelessness, difficulty concentrating, sleep difficulties, an increase or decreased appetite, an increase or decrease in sexual desire, chronic fatigue, headache, constipation or diarrhea, or breast swelling and tenderness. Endometriosis. Endometriosis is one of the most common gynecological diseases, affecting more than 6 million women in the United States. This is equal to about 10% of the adult women population. In this condition, portions of functioning endometrial tissue become located outside of their normal sites, which is the uterine cavity. This endometrial tissue is commonly found attached to the ovaries, fallopian tubes, the outer surface of the uterus, the bowels, the area between the vagina and the rectum, called the rectovaginal septum, and the pelvic side wall. The places where the tissue attaches are called implants or lesions. Endometrial tissue found outside the uterus responds to hormones released during the menstrual cycle in the same way that the endometrial lining does within the uterus. At the beginning of the menstrual cycle, when the lining of the uterus is shed and menstrual bleeding occurs, these abnormally located implants also swell and also bleed. In short, the woman with endometriosis experiences several mini periods throughout her abdomen wherever this endometrial tissue exists. It is not currently known why endometrial tissue becomes transplanted and grows in other parts of the body. Several theories exist, but to date none have been scientifically proven. However, several factors are known to increase a woman's risk of developing endometriosis. This includes increasing age, a familial history of endometriosis in a first-degree relative, short menstrual cycles less than 28 days long, a long menstrual flow of more than 1 week, a high dietary fat consumption, a young age of menarche younger than 12 years of age, and few, 1 or 2 or no pregnancies. Therapeutic management of the client with endometriosis needs to take into consideration the following factors: the severity of the symptoms, the desire for fertility, the degree of the disease, and the client's therapy goals. The aim of therapy is to suppress levels of estrogen and progesterone, which cause the endometrium to grow. Treatment can include surgery or medications such as oral contraceptives, Depo-Provera, synthetic testosterone, and GnRH agonists. The two most common symptoms for women with endometriosis is infertility and pelvic pain. Endometriosis occurs in about 38% of infertile women and 71 to 87% of women with chronic pelvic pain. About 30 to 40% of women with this condition are infertile, making it one of the top 3 causes of female infertility. The pelvic examination typically correlates with the extent of the endometriosis. The usual finding is nonspecific pelvic tenderness. The hallmark finding is the presence of tender nodular masses on the uterosacral ligaments, the posterior uterus, or the posterior cul-de-sac. The only definitive diagnosis is one that's made during surgery. After a thorough history and pelvic examination, the healthcare practitioner may suspect endometriosis, but the only certain method of diagnosis is by seeing it. Pelvic or transvaginal ultrasound is used to assess pelvic organ structures. However, a laparoscopy is needed to truly diagnose endometriosis. Laparoscopy is the direct visualization of the internal organs with a lighted instrument that is inserted through an abdominal incision. A tissue biopsy of the suspected implant is then taken at the same time and examined microscopically to confirm the diagnosis. Infertility. Infertility is defined as the inability to conceive a child after 1 year of regular sexual intercourse, unprotected by contraception. Secondary infertility is the inability to conceive after a previous pregnancy. Many people take the ability to conceive and produce a child for granted, but infertility affects more than 6 million Americans, or 15% of reproductive age population. Of the reproductive age population, infertility is a widespread problem that has emotional, social, and economic impacts on couples. Infertility affects relationships, leads to tension and anger between partners, and can result in severe sexual dysfunction and breakdown of the relationship. Nurses must recognize infertility and understand its causes and treatment options so that they can help couples understand the possibilities as well as the limitations of current therapies. Nurses have a central role in supporting couples through these stressful treatments. Couples will frequently confide in their nurse and can gain great benefit from a sympathetic and sensible discussion. Recent studies have found that women wish to be treated with respect and dignity and given appropriate information and support. They want their distress recognized and they want to feel cared for. Women want to be confident in healthcare professionals in situations where outcomes remain uncertain. The caring aspect of a professional nurse is an essential component of meeting the special needs of these couples. Prevention of infertility through education should also be incorporated into any client-nurse interaction. Reproduction requires the interaction of the female and male reproductive tracts, which involves 1. The release of normal preovulatory oocytes, 2. The production of adequate spermatozoa, 3. The normal transport of these gametes to the ambulatory portion of the fallopian tube, and 4. The subsequent transport of the cleaving embryo into the endometrial cavity for implantation and fetal development. Multiple known and unknown factors affect fertility. Female factor infertility is detected in about 40% of cases. Male factor infertility is also in about 40% of cases. The remaining 20% fall into a category of combined, meaning both male and female factors, or unexplained infertility. In women, ovarian dysfunction and tubal pelvic pathology are the primary contributing factors to infertility. Risk factors for infertility in women include being under or overweight, hormonal imbalances, uterine fibroids, tubal blockages, cervical stenosis, reduced oocyte quality, chromosomal abnormalities, congenital anomalies of the uterus, immune system disorders, chronic illnesses such as diabetes, thyroid disease, or asthma, sexually transmitted infections, an age older than 27, endometriosis, Turner syndrome, a history of pelvic inflammatory disease, smoking and alcohol consumption, multiple miscarriages, exposure to chemotherapeutic agents, and psychological distress. Risk factors for infertility in men include exposure to toxic substances, cigarette or marijuana smoke, heavy alcohol consumption, use of certain prescription drugs for psoriasis or ulcers, exposure of the genitals to high temperatures such as hot tubs or saunas, a hernia repair, obesity that may be associated with decreased sperm quality, Cushing's syndrome, frequent long-distance cycling or running, sexually transmitted infections, undescended testes called cryptorchidism, or mumps that occur after puberty. The majority of infertility cases are treated with drugs or surgery. Various ovulation enhancement drugs and timed intercourse may be used for women with ovulatory problems. The woman should understand a drug's benefits and side effects before consenting to take it. Depending on the type of drug used and the dosage, some women may experience multiple births. If the woman's reproductive organs are damaged, surgery can be done to repair them. Still, other couples might opt for the high-tech approaches of artificial insemination, in vitro fertilization, and egg donation, or they may contract for a gestational carrier or surrogate. Home ovulation predictor kits may help. Home ovulation predictor kits contain monoclonal antibodies specific for luteinizing hormone and the use of ELISA tests to determine the amount of luteinizing hormone, or LH, present in the urine. A significant color change from baseline indicates the LH surge and presumably the most fertile day of the month for women. There is also a clomiphene citrate challenge test, which is used to assess a woman's ovarian reserve, or put more simply, the ability of her eggs to become fertilized. Follicle-stimulating hormone levels, or FSH levels, are drawn on cycle day 3 and on cycle day 10 after the woman takes 100 milligrams of clomiphene citrate on cycle days 5 through 9. If the FSH level is greater than 15, the result is considered abnormal and the likelihood of conception with her own eggs remains very low. Another method, hysterosalpingography. 3 to 10 milliliters of an opaque contrast medium is slowly injected through a catheter into the endocervical canal so that the uterus and tubes can be visualized during fluoroscopy and radiography. If the fallopian tubes are patent, the dye will descend upward to distend the uterus and the tubes and will spill out into the peritoneal cavity. A laparoscopy can also be used early in the menstrual cycle. It is not part of the routine infertility evaluation, but it is used when abnormalities are found on ultrasound or using the hysterosalpingogram. Because of the added risks of surgery, the need for anesthesia, and the operative costs, laparoscopy is only used when it is clearly indicated. During this procedure, an endoscope is inserted through a small incision in the anterior abdominal wall. Visualization of the peritoneal cavity in an infertile woman may reveal endometriosis, pelvic adhesions, tubal occlusions, fibroids, or polycystic ovaries. Contraception. Contraception is any method that prevents conception or childbirth, including oral contraceptives, sterilization of the female, and the male condom, which are the most popular methods in the United States. There are also many additional types of contraceptives discussed here. In the United States, there are approximately 68 million women in their childbearing years between the ages of 15 and 44, and throughout those years, a variety of contraceptive methods may be used. Studies have shown that 98% of sexually active women in the United States admit to having used at least one form of contraception. However, despite widespread use of contraceptives, almost 1/2 of all pregnancies in the United States are unintended, accounting for a higher unintended pregnancy rate than in other Western countries. In addition to unwanted pregnancies, which can result in abortion, some contraceptives also help to prevent transmission of STDs and HIV. 15 people in the United States become infected with HIV every minute of every day. Much of this suffering could be prevented by access to and consistent use of safe, efficient, appropriate, modern contraception for everyone who wants it, as well as proper education regarding benefits and instructions for use. Contraceptive methods can be divided into 4 basic types: behavioral methods, barrier methods, hormonal methods, and permanent methods. Women must decide which method is appropriate for them to meet their changing contraceptive needs throughout their life cycles. Nurses can educate and assist women during the selection process. In an era where many women wish to delay pregnancy and to avoid STIs, choices can become difficult. There are numerous methods of contraception available today, and many more will be offered in the near future. The ideal contraceptive method for many women would have to have the following characteristics: ease of use, safety, effectiveness, minimal side effects, naturalness, non-hormonal methods, and immediate reversibility. Currently, no single contraceptive method offers all of these things. Abstinence, which is not having vaginal or anal intercourse, is one of the least expensive forms of contraception and has been used for thousands of years. Basically, pregnancy cannot occur if sperm is kept out of the vagina. It also reduces the risk of contracting HIV or AIDS and other STIs unless bodily fluids are exchanged through oral sex. However, some infections such as herpes and human papillomavirus or vaginal warts can be passed by skin-to-skin contact. There are many pleasurable options for sex play without intercourse, called outercourse, such as kissing, mutual masturbation, erotic massage, sexual fantasy, and using sex toys or safe oral sex. Many people have strong feelings about abstinence based on religious or moral beliefs. There are many good and personal reasons to choose abstinence. For some, it is a way of life, whereas for others, it is a temporary choice. Some people choose abstinence because they want to wait until they are older, wait for a long-term relationship, avoid pregnancy or STIs, or follow religious or cultural expectations. Fertility awareness refers to any natural contraceptive method that does not require hormones, pharmaceutical compounds, physical barriers, or surgery to prevent pregnancy. Fertility awareness-based methods use physical signs and symptoms that change with the hormonal fluctuations that occur throughout a woman's menstrual cycle to prevent fertility. The unifying theme of fertility awareness methods is that a woman can reduce her chance of pregnancy by abstaining from coitus or using barrier methods during certain times of the menstrual cycle. These methods require couples to take an active role in preventing pregnancy through their sexual behaviors. Couples agree to practice certain techniques, use calculations, and be observant of the fertile and safe periods within the monthly menstrual cycle. The normal physiological changes caused by hormonal fluctuations during the menstrual cycle can be observed and charted. This information can then be used to avoid or promote pregnancy. Fertility awareness methods rely on the following assumptions. First, that a single ovum is released from the ovary 14 days before the next menstrual period, and it lives for approximately 24 hours. 2. Sperm can live up to 5 days after intercourse. The unsafe period during the menstrual cycle is thus approximately 6 days, 3 days before and 3 days after ovulation. Because body changes start to occur before ovulation, the woman can become aware of them and not have intercourse on these days, or use another method to prevent pregnancy. The exact time of ovulation cannot be determined, so 2 to 3 days are added to the beginning to avoid pregnancy. Techniques used to determine fertility include cervical mucus ovulation method, the basal body temperature method, the symptothermal method, standard days method, and the 2-day method. Fertility awareness methods are moderately effective, but are very unforgiving if not carried out precisely. Fertility awareness can be used in combination with coital abstinence or barrier methods during fertile days if pregnancy is not desired. The cervical mucus ovulation method is used to assess the characteristics of the cervical mucus. Cervical mucus changes in consistency during the menstrual cycle and plays a vital role in the fertilization of the egg. Studies conducted by the World Health Organization indicate that 93% of women, regardless of their educational level, are capable of identifying and distinguishing fertile and infertile cervical secretions. In the days preceding ovulation, fertile cervical mucus helps draw sperm up into the fallopian tubes, where fertilization usually takes place. It also helps maintain the survival of sperm. As ovulation approaches, the mucus becomes more abundant, clear, slippery, and smooth. It can be stretched between two fingers without breaking. Under the influence of estrogen, this mucus looks like egg whites. It is called spinbarchet mucus. After ovulation, the cervical mucus becomes thick and dry under the influence of progesterone. The cervical position can also be assessed to confirm the changes in cervical mucus at ovulation. Near ovulation, the cervix feels soft and high up or deep in the vagina. The os is slightly open and the cervical mucus is copious and slippery. This method works because the woman becomes aware of the bodily changes that accompany her ovulation. When she notices them, she can abstain from sexual intercourse or use another method to prevent unwanted pregnancy. Each woman is an individual, so each woman's unsafe time of the month is unique and thus must be individually assessed and determined. The basal body temperature method. The basal body temperature, or BBT, refers to the lowest temperature reached upon awakening. The woman takes her temperature orally before rising and records it on a chart. Pre-ovulation temperatures are suppressed by estrogen, whereas post-ovulation temperatures are increased under the influence of heat-inducing progesterone. Temperatures typically rise within a day or two after ovulation and remain elevated for approximately 2 weeks, at which point bleeding usually begins. If using this method by itself, the woman should avoid unprotected intercourse until the basal body temperature has been elevated for 3 days. Other fertility awareness methods should be used along with the basal body temperature method for better results. The symptothermal method relies on a combination of techniques to recognize ovulation, including basal body temperature, cervical mucus changes, alterations in the position and firmness of the cervix, and other symptoms of ovulation, including increased libido, mitral smirk, pelvic fullness or tenderness, and breast tenderness. Combining all these predictors increases awareness of when ovulation occurs and increases effectiveness of this method. A home predictor test for ovulation is also available in most pharmacies. These tests measure LH levels to pinpoint the day before or the day of ovulation. These tests are widely used for fertility and infertility regimens. The standard days method and the 2-day methods are both natural methods of contraception developed by Georgetown University's Medical Center Institute of Reproductive Health. Both methods provide women with simple, clear instructions for identifying fertile days. Women with menstrual cycles between 26 and 32 days long can use this method to prevent pregnancy by avoiding unprotected intercourse on days 8 through 19 of their cycles. An international clinical trial of the standard days method showed that the method is more than 95% effective when used correctly. The standard days method identifies the 12-day fertility window of a woman's menstrual cycle. These 12 days take into account the lifespan of a woman's egg, which is about 24 hours, as well as the viability of the sperm, which is about 5 days, and the variation in the actual timing of ovulation from one cycle to another. For the 2-day method, women observe the presence or absence of cervical secretions by examining toilet paper or underwear, or by monitoring their physical sensations. Every day, the woman asks 2 simple questions. Did they note any secretions yesterday? And did they note any secretions today? If the answer to either question is yes, she considers herself fertile and avoids unprotected intercourse. If the answers are no, she is unlikely to become pregnant from unprotected intercourse on that day. To help women keep track of the days on which they should avoid unprotected intercourse, a string of 32 colored beads called cycle beads are used. Each bead represents a day of the menstrual cycle. Starting with the red bead, which represents the first day of her menstrual cycle, the woman moves a small rubber ring, one bead each day. The brown beads are the days in which pregnancy is unlikely, and the white beads represent fertile days. There is also the withdrawal or coitus interruptus method. In coitus interruptus, also known as the withdrawal method, a man controls his ejaculation during sexual intercourse and ejaculates outside of the vagina. It is better known colloquially as pulling out. It is one of the oldest and most widely used means of preventing pregnancy in the world. The problem with this method is that the first few drops of true ejaculate contain the greatest concentration of sperm, and if some pre-ejaculatory fluid does escape from the urethra before orgasm, conception may still occur. This method requires that the woman relies solely on the cooperation and judgment of the man. There is also the lactational amenorrhea method. The lactational amenorrhea method, or LAM, is an effective temporary method of contraception used by breastfeeding mothers. Continuous breastfeeding can postpone ovulation and thus prevent pregnancy. Breastfeeding stimulates the hormone prolactin, which is necessary for milk production. It also inhibits the release of another hormone called gonadotropin, which is necessary for ovulation. Breastfeeding as a contraceptive method can be effective for 6 months after delivery, only if a woman has not had a period since she gave birth, breastfeeds her baby at least 6 times a day on both breasts, breastfeeds her baby on demand at least every 4 hours, does not substitute other foods for breast milk, provides nighttime feedings at least every 6 hours, and does not rely on this method after 6 months of time. There are also many barrier contraceptive methods. Barrier contraceptives are forms of birth control that prevent pregnancy by preventing the sperm from reaching the ovum. Mechanical barriers include condoms, diaphragms, cervical caps, and sponges. These devices are placed over the penis or over the cervix to physically obstruct the passage of the sperm into the cervix. Chemical barriers, called spermicides, may also be used along with mechanical barrier devices. Spermicides come in creams, jellies, foams, suppositories, and vaginal films. Spermicides work by chemically destroying the sperm in the vagina. These contraceptives are called barrier methods because they not only provide a physical barrier for the sperm, but also protect against STIs. Many of these barrier methods contain latex. Allergy to latex was first recognized in the late 1970s, and since it has become a major health concern with increasing numbers of people affected. According to the American Academy of Allergy, Asthma, and Immunology, 6% of the general population, 10% of healthcare workers, and 50% of spina bifida patients are sensitive to natural rubber latex. Healthcare workers in both the medical and dental environments, as well as specific groups of individuals, including those with spina bifida, myelodysplasia, and food allergies to banana, kiwi, avocado, and others, are at risk of latex sensitivity. The symptoms of latex allergy include skin rash, itching, and hives, itching or burning eyes, swollen mucous membranes in the genitals, shortness of breath, difficulty breathing or wheezing, and anaphylactic shock. Use of or contact with a latex condom, cervical cap, or diaphragm is contraindicated for men and women with a latex allergy. If the female partner is allergic to latex, have the male partner apply a natural condom over the latex one. If the male partner experiences penile irritation after condom use, try different brands, or place the latex condom over a natural condom. You may also use polyurethane condoms rather than latex ones, or use female condoms made of polyurethane. Alternatively, you could switch to another birth control method that isn't made with latex, such as oral contraceptives, intrauterine devices, Depo-Provera, fertility awareness, and other non-barrier methods. However, these methods do not protect against sexually transmitted infections. Condoms. Condoms are barrier methods of contraceptives made for both males and females. The male condom is made from latex or polyurethane or a natural membrane and may be coated with a spermicidal agent. Male condoms are available in many colors, textures, sizes, shapes, and thicknesses. When used correctly, the male condom is put over an erect penis before it enters the vagina and is worn throughout the duration of sexual intercourse. Condoms serve as a barrier to prevent pregnancy by trapping seminal fluid and sperm and offers protection against sexually transmitted infections. Condoms are not perfect barriers, however. Breakage and slippage can occur. Emergency postcoital contraception may be needed to prevent a pregnancy in the case of a breakage or slippage. In addition, the non-latex condoms have a higher risk of pregnancy and higher risk of STIs than latex condoms. The female condom is a polyurethane pouch which is inserted into the vagina. It consists of an outer and inner ring that is inserted vaginally and held in place by the pubic bone. Some women complain that the female condom is cumbersome to use and makes noise during intercourse. Female condoms are readily available, are inexpensive, and can be carried inconspicuously by the woman. The female condom was the first woman-controlled method that offered protection against pregnancy and some STIs. Nurses can play a key role in influencing clients to initiate and maintain the use of female condoms, which is an underused method for STI prevention and prevention of unwanted pregnancy in the United States. The diaphragm. The diaphragm is a soft latex dome surrounded by a metal spring. Used in conjunction with a spermicidal cream or jelly, this diaphragm is inserted into the vagina to cover the cervix. The diaphragm may be inserted up to 4 hours before intercourse, but must be left in place for at least 6 hours after intercourse. Diaphragms are available in a range of sizes and styles. The diaphragm is available only by prescription and must be professionally fitted by a healthcare professional. Women may need to be refitted with different sizes of diaphragms after pregnancy, abdominal or pelvic surgery, or weight loss or gain of more than 10 pounds. As a rule, diaphragms should be replaced every 1 to 2 years. Cervical caps. The cervical cap is smaller than the diaphragm and covers only the cervix. It is held in place by suction. Caps are made from silicone or latex and are used with spermicidal agents. The Prentive cap and the Fem cap are the only cervical cap devices that are approved in the United States as of 2011. The cap may be inserted up to 12 hours before intercourse and provides 48 hours of protection. The cap must be kept in the vagina 8 hours after the final act of intercourse and should be replaced every 1 to 2 years. A refitting may also be necessary when the woman experiences pregnancy, abortion, or weight changes. The dome of the cap is filled about 1/3 full with a spermicidal agent. Spermicide should not be applied to the rim because it may interfere with the seal that must form around the cervix. The cap is only available by prescription and must be fitted by a healthcare professional. Contraceptive sponges. The contraceptive sponge is a non-hormonal, non-prescription device that includes both a barrier and a spermicide. The contraceptive sponge is a soft, concave device that prevents pregnancy by covering the cervix and releasing spermicide. The sponge, made of polyurethane impregnated with a spermicidal agent called nonoxidil 9, releases 125 milligrams of the spermicide over 24 hours of use. Unlike the diaphragm, the sponge can be used for more than one coital act within 24 hours without the insertion of additional spermicidal agents. And the sponge does not require a fitting or a prescription from a healthcare provider. While the sponge is less effective than several other methods, it does not offer protection against STIs. However, the sponge has achieved a wide following among women who appreciate the spontaneity with which it can be used and its ease of availability. To use the sponge, the woman first wets it with water and then inserts it into the vagina with a finger using a cord loop attachment. It can be inserted up to 24 hours before intercourse and should be left in place at least 6 hours following intercourse. The sponge provides protection for up to 12 hours, but should not be left in place for more than 30 hours after insertion to avoid the risk of toxic shock syndrome. The sponge is a contraceptive method, but it does not protect against sexually transmitted diseases or infections. There are also several hormonal methods available to women who want long-term but not permanent protection against pregnancy. These methods of contraception work by altering the hormones within the woman's body. These hormonal methods rely on estrogen and progestin, or progesterone alone, to prevent ovulation. When used consistently, these methods are the most reliable way to prevent pregnancy. Hormonal methods include oral contraceptives, injectables, implants, vaginal rings, and transdermal patches. As early as 1937, scientists recognized that the injection of progesterone inhibited ovulation in rabbits and provided contraception. Breakthrough bleeding was reported in early clinical trials in women, and the role of estrogen in the cycle control was launched. This established the rationale for a modern combination oral contraceptives that contain both estrogen and progesterone. Development of hormonal contraception marked a revolutionary step in social change that was to improve the lives of women and families worldwide. Since the first oral contraceptive was introduced in the 1960s, hormonal contraception has undergone various stages of advancement. Today, oral contraceptive regimens are safer and more tolerable, with equal or improved efficacy than the early formulations. In 1960, the FDA approved the first combination oral contraceptive, called Inovoid 10, which composed of 150 micrograms of estrogen and 9 milligrams of progesterone for use in the United States. Today, nearly 30 combination oral contraceptives are available in the United States. The most notable change over the last 50 years of oral contraceptive improvement has been the lowering of the estrogen dose to as low as 20 micrograms and the introduction of new progestins. Oral contraceptives are the most popular method of non-surgical contraception and are used approximately by 25 million women in the U.S. Unlike the original oral contraceptives that women took decades ago, the new low-dose forms carry fewer health risks. Although most commonly prescribed for contraception, oral contraceptives have long been used for the management of a wide range of conditions and actually has many health benefits, such as reduced incidence of ovarian and endometrial cancer, prevention and treatment of endometriosis, decreased incidence of acne and hirsutism, decreased incidence of ectopic pregnancy, decreased incidence of pelvic inflammatory disease, reduced incidence of fibrocystic breast disease, and decreased perimenopausal symptoms, including reduction in the risk of the development of uterine fibroids, the maintenance of bone and mineral density, and possible protection against pelvic inflammatory disease. Also, there is an increase in menstrual regularity and a lower incidence of colorectal cancer. There is also a decrease in pregnancy-related deaths by preventing pregnancy and reducing iron deficiency anemia by treating menorrhagia, and reduced incidence of dysmenorrhea. Oral contraceptives work by suppressing ovulation by adding estrogen and progesterone to a woman's body, thus mimicking pregnancy. This hormonal level stifles gonadotropin-releasing hormone, or GnRH, which in turn suppresses follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH, and thus inhibits ovulation. Cervical mucus also thickens, which hinders sperm transport into the uterus. Implantation is inhibited by suppression of the maturation of the endometrium and alterations of uterine secretions. The combination pills are prescribed as monophasic pills, which deliver a fixed dosage of estrogen and progestin, or as multiphasic ones. Multiphasic pills, including biphasic and triphasic oral contraceptives, alter the amount of progestin and estrogen within each cycle. Oral contraceptives should be taken at the same time every day. Oral contraceptives that contain progestin only are called mini pills, and they are prescribed for women who cannot take estrogen. They work primarily by thickening the cervical mucus to prevent the penetration of the sperm and to make the endometrium unfavorable for implantation. Progestin-only pills must be taken at a certain time every 24 hours. Breakthrough bleeding and a higher risk of pregnancy have made these mini pills less popular than the combination pills. Extended oral contraceptive regimens have been used for the management of menstrual disorders and endometriosis for years, but now are attracting wider attention. Surveys asking women about their willingness to reduce their menstrual cycles from 12 to 4 annually were returned with a resounding yes. Research has confirmed that the extended use of active oral contraceptive pills carries the same safety profile as the conventional 28-day regimens. The extended regimen consists of 84 consecutive days of active combination pills, followed by 7 days of placebo. The woman has 4 withdrawal bleeding episodes a year. Seasonal and Seasonique are combination oral contraceptives, which are on the market for those women who choose to reduce the number of periods they have. In 2009, the makers of Seasonique came out with Low Seasonique. Low Seasonique consists of 84 orange tablets containing 0.1 milligrams of levonorgestrel and 0.02 milligrams of ethinyl estradiol, along with 7 yellow tablets containing 0.01 milligrams ethinyl estradiol. The balance between the benefits and risks of oral contraceptives must be determined for each individual woman. Oral contraceptives are highly effective when taken properly, but they can aggravate many medical conditions, especially in women who smoke. Injectable contraceptives. Depo-Provera is a trade name for an injectable form of a progesterone-only contraceptive given every 12 weeks. Depo-Provera works by suppressing ovulation and the production of FSH and LH by the pituitary gland, thereby increasing the viscosity of the cervical mucus and causing atrophy of the endometrial lining. A single injection of 150 milligrams acts like other progestin-only products to prevent pregnancy for 3 months at a time. The primary side effect of Depo-Provera is menstrual cycle disturbances. Transdermal patches. A transdermal patch, such as Ortho-Evra, is also available. Ortho-Evra is a matchbox-sized patch containing hormones that are absorbed through the skin when placed on the lower abdomen, upper outer arm, buttocks, or upper torso, avoiding the breasts. The patch is applied weekly for 3 weeks, followed by a patch-free week during which withdrawal bleeding occurs. The patch delivers continuous levels of progesterone and estrogen. Transdermal absorption allows the drug to enter the bloodstream directly, avoiding rapid inactivation in the liver, known as first-pass metabolism. Because estrogen and progesterone are metabolized by liver enzymes, avoiding such first-pass metabolism was thought to reduce adverse side effects. However, recent evidence suggests that the risk of venous thrombosis and embolism is increased with the patch, and the risk of skin burns may occur if undergoing an MRI. Additional studies are underway to understand the clinical significance of the latest findings, but in the interim, nurses need to focus on the ongoing risks and assessment to discuss current research findings with clients. Compliance with combination contraceptive patches has been shown to be significantly greater than compliance with oral contraceptives. The patch provides combination hormone therapy with a side effect profile that is similar to oral contraceptives. Vaginal rings. The contraceptive vaginal ring is a soft, flexible, transparent ring that is inserted by the user for a 3-week period of continuous use, followed by a ring-free week, allowing for withdrawal bleeding to occur. Ethinyl estradiol and etonogestrel are rapidly absorbed through the vaginal epithelium and result in a steady stream of serum concentration. Studies have demonstrated that the efficacy and safety of the ring are equivalent to those of oral contraceptives. Clients report being highly satisfied with the vaginal ring and report fewer systemic side effects. The ring provides effective cycle control as well as symptom relief for women with menorrhagia, dysmenorrhea, and polycystic ovarian syndrome. The ring can be inserted by the woman and does not have to be fitted. The woman can compress the ring and it inserts into the vagina behind the pubic bone as far back as possible, but precision placement is not critical. The hormones are absorbed through the vaginal mucosa and left in place for 3 weeks, after which it is removed and discarded. Effectiveness and adverse events are similar to those as seen with combination oral contraceptives. The implant is a subdermal time-release method that delivers synthetic progestin, which inhibits ovulation. Once in place, it delivers 3 years of continuous, highly effective contraception. Like progestin-only pills, implants act by inhibiting ovulation and thickening cervical mucus so that the sperm cannot penetrate. A single rod progestin implant received FDA approval in 2006, and as of 2011, was the only available implant in the United States. Since then, several more have come into being. Hormonal side effects are not exclusive to implants, but tend to be a problem with all hormonal contraceptives. Pre-insertion counseling by a nurse is essential to prepare the woman for any such side effects. Expert counseling should cover the side effects that are most likely to cause discontinuation, including initial irregular bleeding and possibility of amenorrhea with longer use. Intrauterine contraceptives. An intrauterine contraceptive is a small plastic T-shaped object which is placed inside the uterus to provide contraception. It prevents pregnancy by making the endometrium of the uterus hostile to implantation of a fertilized ovum by causing a nonspecific inflammatory reaction and inhibiting the sperm and ovum from meeting. The hormonal IUC, or intrauterine contraceptive, will make monthly periods lighter, shorter, and less painful, making this a useful method for women with heavy painful periods. Some implants may contain copper or progesterone to enhance their effectiveness. 1 or 2 attached strings protrude into the vagina so that the user can check for placement. Emergency contraception. Unplanned pregnancy is a major health, economic, and social issue for women. Approximately 1/3 of all unplanned pregnancies end in abortion. Using an emergency contraceptive is a woman's last chance to prevent an unintended pregnancy. Emergency contraceptive, also known as EC, reduces the risk of pregnancy after unprotected intercourse or contraceptive failure, such as a condom breakage. Emergency contraception is used within 72 hours of unprotected intercourse to prevent pregnancy. The sooner the ECs are taken, the more effective they are. They reduce the risk of pregnancy for a single act of unprotected sex by almost 80%. The methods available in the United States are progestin-only pills, Plan B one-step, combined estrogen and progesterone pills, or insertion of a copper-releasing intrauterine system up to 7 days after unprotected intercourse. Olipristal acetate, marketed as Ella, is a selective progesterone receptor modulator that, when taken as a single 30 mg dose, is a new, safe, and effective emergency contraceptive that can be used from the first day up to 5 days following unprotected intercourse. The older progesterone-only emergency contraceptives, such as levonorgestrel, is taken as 2 0.75 mg pills 12 hours apart, or a single 1.5 mg pill, as in the brand Next Choice, or as a single 1.5 mg pill, as in the brand Plan B one-step. These are approved for only 72 hours after unprotected intercourse. Sterilization. Sterilization is an attractive method of contraception for those who are certain that they do not want to have any or any more children. Sterilization refers to surgical procedures intended to render a person infertile. Sterilization is a safe and effective form of permanent birth control. In the United States, it is the second most commonly used form of contraception overall, and it is the most frequently used method among married women and among women over 30 years of age. More women than men undergo surgical sterilization. According to the CDC, approximately 18% of women undergo female sterilization, in comparison to only 7% of men in the United States. Sterilization should be considered a permanent end to fertility, because reversal surgery is difficult, expensive, and not highly successful. Tubal ligation. Tubal ligation is the sterilization procedure for women and can be performed postpartum after an abortion or as an interval procedure unrelated to pregnancy. A laparoscope is inserted through a small subumbilical incision to provide a view of the fallopian tubes. The fallopian tubes are then grasped and sealed with a cauterizing instrument, or with rings, bands, or clips, or are cut and tied. This procedure is called transcervical sterilization and offers several advantages over the conventional tubal ligation methods. For example, general anesthesia and incisions are not needed, thereby increasing safety, lowering costs, and improving access to sterilization procedures. Vasectomy. Male sterilization is accomplished with a surgical procedure known as a vasectomy. It is usually performed under local anesthesia in a urologist's office, and most men can return to work and normal activities in a day or two. The procedure involves making a small incision into the scrotum and cutting the vas deferens, which carries the sperm from the testes to the penis. Complications from vasectomy are rare and minor in nature. Immediate risks include infection, hematoma, and pain. After a vasectomy, semen no longer contains the sperm. This is not immediately, however, and the man must submit semen specimens for analysis until 2 specimens show that no sperm is present. When the specimen shows a lack of sperm, the man's sterility is then confirmed. One's contraceptive method is a very personal choice and involves many factors. What makes one woman choose one contraceptive method over another? In making contraceptive choices, couples must balance their sex lives, reproductive goals, and partners' health and safety. The search for the choice that satisfies all 3 of these objectives may be challenging. A method that works for a sexually active teenage girl may not meet her needs later in life. Several considerations influence a person's choice of contraceptives, including cultural and religious beliefs, motivation, future reproductive plans, and cost. In addition, factors such as convenience, effectiveness, side effects, desire for children in the future, safety of the method, comfort level with sexuality, protection from STIs, and interference with spontaneity may play a role. If a contraceptive is to be effective, the woman must understand how it works, must be able to use it correctly and consistently, and must be comfortable and confident with it. If a client cannot comply with taking a pill daily, they should consider a method used once a week, such as a transdermal patch, or once every 3 weeks, such as a transvaginal ring, or even once every 3 months with an injection such as Depo-Provera. Another option may be a progesterone intrauterine device that lasts 3 to 5 years and reduces menstrual flow significantly. Regardless of which method is chosen, the client's needs should be paramount in the discussion. Nurses can educate clients about which methods are available and their advantages, disadvantages, efficacy, costs, and safety. Counseling can help a woman choose contraceptive methods that are efficacious and fits her preference and lifestyle. Menopausal transition. Meno is derived from a Greek word meaning month, and pause is derived from a Greek word meaning to pause or to halt. Menopause is the technical term for a point in time at which menses and fertility ceases. The change of life, the end of fertility, the beginning of freedom. Whatever people call it, menopause is a unique and personal experience for every woman. The term menopausal transition refers to the transition from a woman's reproductive phase of her life to her final menstrual period. The period is also referred to as perimenopause. It is the end of her menstruation and childbearing capacity. The average age of natural menopause, which is defined as 1 year without a menstrual period, is 51.4 years of age. The average age of natural menopause has remained consistent for the last several hundred years, despite improvements in nutrition and healthcare. With current female life expectancy at 84 years, this event comes in the middle of a woman's adult life. Menopause signals the end of an era for many women. It concludes their ability to reproduce, and some women find advancing age, altered roles, and the psychological changes to be overwhelming events that may precipitate an anxiety or depression. Menopause does not happen in isolation. Midlife is often experienced as a time of change and reflection. Change happens in many arenas. Children are leaving or maybe returning home. Employment pressures intensify as career moves or decisions are required. Elderly parents may require more care, or the death of a parent may have a major impact. And partners are retrenching or undergoing their own midlife crises. Women must negotiate all of these changes in addition to menopause. Managing these stressful changes can be very challenging for many women as they make the transition into midlife. A woman is born with approximately 2 million ova, but only about 400 ever mature fully to be released during the menstrual cycle. The absolute number of ova in the ovary is a major determinant of fertility. Over the course of her premenopausal life, there is a steady decline in the number of immature ova. Science is still struggling to understand this depletion, but it does not occur in isolation. Maturing ova are surrounded by follicles that produce two major hormones, estrogen in the form of estradiol and progesterone. The cyclic maturation of the ovum is directed by the hypothalamus. The hypothalamus triggers a cascade of neurohormones, which act through the pituitary and the ovaries as a pulse generator for reproduction. The hypothalamic pituitary ovarian axis begins to break down long before there is any sign that menopause is imminent. Some scientists believe that this pulse generator in the hypothalamus simply degenerates. Others speculate that the ovary becomes more resistant to pituitary hormone FSH and simply shuts down. The final act in this well-orchestrated process is amenorrhea, or the absence of menstruation. As menopause approaches, more and more of the menstrual cycles become anovulatory. This period of time, usually 2 to 8 years before the cessation of menstruation, is termed perimenopause. In perimenopause, the ovaries begin to fail, producing irregular and missed periods and occasional hot flashes. When menopause finally appears, viable ova are gone. Estrogen levels plummet by 90%, and estrone, produced in fat cells, replaces estradiol as the body's main form of estrogen. The major hormone produced by ovaries during the reproductive years is estradiol. The estrogen found in postmenopausal women is estrone. Estradiol is much more biologically active than estrone. In addition, testosterone levels decrease with menopause. Menopausal transition, with its dramatic decline in estrogen, affects not only the reproductive organs, but also other body systems. The brain experiences hot flashes, disturbed sleep, mood, and memory problems. The cardiovascular system has lower levels of high-density lipoprotein, or HDL, and an increased risk of cardiovascular disease. The skeletal system experiences a rapid loss of bone density that increases the risk of osteoporosis. The breasts undergo a replacement of duct and glandular tissues by fat. The genitourinary system experiences vaginal dryness, stress incontinence, and cystitis. The gastrointestinal tract may experience less absorption of calcium from food and an increase in the risk of fractures. The integumentary system may experience dry, thin-skinned, and decreased collagen levels. And the body shape may change to show more abdominal fat with a waist size that swells relative to the hips. Menopausal transition should be managed individually. In the past, despite a wide diversity of symptoms and risks, the traditional reaction was to reach for a one-size-fits-all therapy called hormone therapy. Today, the medical community is changing its thinking in light of the Women's Health Initiative. The Heart and Estrogen Progesterone Replacement Study reported that long-term hormonal therapy increased the risk of heart attacks, strokes, and breast cancer. In short, the overall health risks of hormone therapy were deemed to exceed the benefits. A number of treatment options are available, but factors in the client's history should be the driving force when determining therapy. Hormone replacement therapy is approved for 2 indications: the relief of vasomotor symptoms and prevention of osteoporosis. Research suggests that replacement therapy may be beneficial for preventing diabetes, improving mood, or avoiding urinary tract problems. Many women consider non-hormonal therapies, such as biphosphonates and selective estrogen receptor modulators, or SERMs. Consider weight-bearing exercises, calcium, vitamin D, smoking cessation, and avoidance of alcohol to treat or prevent osteoporosis. Annual breast examinations and mammograms are essential. Local estrogen creams can be used for vaginal atrophy. Consider herbal therapies for symptoms. Although numerous symptoms have been attributed to menopause, some of them are more closely related to the aging process than estrogen deficiency. Common symptoms of menopause include hot flashes or flushes of the head and neck, dryness in the eyes and vagina, personality changes, anxiety and depression, loss of libido, decreased lubrication, weight gain and water retention, night sweats, atrophic changes including loss of elasticity in vaginal tissues, fatigue, irritability, poor self-esteem, insomnia, stress incontinence, and heart palpitations. Women are greatly affected by osteoporosis after menopause. Osteoporosis is a condition in which bone mass declines to such an extent that fractures occur with minimal trauma. Bone loss begins in the third or fourth decade of life and accelerates rapidly after menopause. This condition puts many women into long-term care with a resulting loss of independence. Most women with osteoporosis do not know that they have the disease until they sustain a fracture, usually of the wrist or hip. Risk factors include increasing age, postmenopausal status without hormone replacement, small thin-boned frame, low bone mineral density, being Caucasian or Asian with a small bone frame, impaired eyesight that would increase the risk of falling, rheumatoid arthritis, a family history of osteoporosis, a sedentary lifestyle, a history of treatment with antacids containing aluminum, heparin, long-term use of steroids over 3 months, or thyroid replacement drugs. Bone mineral density, or BMD, is a two-dimensional measurement of the average content of mineral in a section of bone. BMD evaluations are made at the hip, femoral neck, and spine. There is a significant relationship between BMD and fracture. As BMD is reduced, the risk of fracture increases. Screening tests to measure bone density are not good predictors for young women who might be at risk for developing this condition. Dual energy X-ray absorptiometry is a screening test that calculates the mineral content of the bone at the spine and hip. It is highly accurate, fast, and relatively inexpensive. The dual energy X-ray absorptiometry scan, or DEXA scan, is the gold standard for radiological methods for identifying osteoporosis through measuring BMD. The best management for osteoporosis is prevention. Women can modify their risks by doing some of the following. Engage in daily weight-bearing exercise, such as walking to increase osteoblast activity. Increase calcium and vitamin D intake. Avoid smoking and excessive alcohol of more than 2 drinks per day. Discuss bone health with the healthcare provider. When appropriate, have a bone density test and take medicine if needed. Medications that can help in preventing and managing osteoporosis include Premarin, which is used in hormone replacement therapy, SERMs, calcium and vitamin D supplement, bisphosphonates, parathyroid hormone, and calcitonin. For the first half of life, estrogen seems to be a protective substance for the cardiovascular system by smoothing, relaxing, and dilating blood vessels. It helps to boost HDL and lower low-density lipoprotein levels, helping to keep the arteries clean and clear of plaque accumulation. But when estrogen levels plummet as a woman ages and experiences menopause, the incidence of cardiovascular disease increases dramatically. Menopause is not the only factor that increases a woman's risk for CVD. Lifestyle and medical history factors, such as the following, may play a major role. Smoking, obesity, a high-fat diet, a sedentary lifestyle, high cholesterol levels, a familial history of cardiovascular disease, hypertension, an apple-shaped body, and diabetes. 2 of the major risks for coronary heart disease are hypertension and dyslipidemia. Both are modifiable and can be prevented by lifestyle changes and, if needed, controlled by medication. Women who experience early menopause lose the protection afforded by endogenous estrogens to the cardiac system and are at greater risk for the more extensive atherosclerosis. Major preventative strategies include a healthy diet, increased activity, exercise, smoking cessation, decreased alcohol intake, and weight reduction. The good news is that CVD is largely preventable. Because CVD is a chronic disease that develops over time, primary prevention of lifestyle modification interventions are the most effective if initiated before the development of the overt disease. Stressing the importance of a lifestyle modification must begin early in life and should be reinforced from the beginning of a young woman's reproductive years throughout menopause. Nurses are in an ideal situation to teach the importance of good nutrition, healthy weight, and daily exercise before cardiovascular disease becomes clinically evident. Healthy lifestyles and stress management techniques are vital to health and longevity, and it is important to keep these on the client's agenda when discussing menopause. Evidence-based interventions include lifestyle modifications, risk management therapies to participate actively in maintaining health, exercise regularly to prevent cardiovascular disease and osteoporosis, take supplemental calcium, and eat appropriately to prevent osteoporosis, stop smoking to prevent lung cancer and heart disease, reduce caffeine and alcohol intake to prevent osteoporosis, monitor blood pressure, lipids, and diabetes, and, if needed, follow the recommended drug therapy. Use a low-dose aspirin to prevent blood clots. Reduce the dietary intake of fat, cholesterol, and sodium to prevent cardiovascular disease. Maintain a healthy weight for your body frame. Perform breast self-examinations for breast awareness, and control stress to prevent depression. These life approaches may seem low-tech, but they can stave off menopause-related complications. Thank you for watching.